So when would see someone, or anyone, physician would see someone with a symptom of back pain or leg pain, the things that are important, and they teach us this in medical school, is first take a very good history, because in this day and age we have so much technology. We've got MRI scans and myelograms and CAT scans, and there's a draw to thinking that, well, let's just get that study, it's going to give us the answers. But a study really should be confirmatory to what your thinking is going on clinically. The most important thing is the history. Where is the pain? If somebody said that they have had back pain that started 6 months ago, it's constant, it's just getting worse and worse and worse, it bothers them constantly, that's not as much a mechanical kind of a back pain as it could be something going on under the surface, like an infection or a tumor or something like that. If someone had a weight loss that was unexplained, fevers and chills, things like that would be keys to identifying some pathologies that could be problematic. Other times, pain can be referred. It can be, if you have a deep aneurysm, a widening of your aorta in the abdomen, that can be a cause of back pain. Hip pathology, almost all the time, mimics sciatica or spinal stenosis. So a lot of my time in the office is asking questions to decide, does this sound like it's a hip arthritis, or does this sound like it's spine related? You can get pain into your legs from sciatica coming down your leg. You can get pain in your legs because you don't have as good of a blood supply to the legs. And that's also common, and a lot of it can be determined by the history. And just basically, if somebody had spinal stenosis, a narrowing of their nerves would be narrow, so typically when they stand and they walk, they oftentimes develop more and more leg pain. They typically wouldn't have trouble getting up from a chair, or they wouldn't have trouble putting on shoes and socks like people with arthritis in their hip would, but they get up fine, but develop pain as they stand and walk, and classically, as soon as they sit down, they get relief. They oftentimes would hang on to a grocery cart in a grocery store, and that's an actual positive cart sign. And it means that they're giving support to the spine, and leaning forward just gives a little more room to the spinal canal. So people with stenosis oftentimes will tell me that they find themselves progressively kind of walking a little bit more bent over, and it's harder to stand up. Now, the person with spinal stenosis could get on a bicycle and do fine. So I often ask that question. Now, the other diagnosis, the blood supply to the leg, would be just the opposite, because if you didn't have enough blood supply to your leg, you wouldn't be able to stay on a bike very much, because those legs are asking for blood, and if they're not getting it, they're going to be painful. So a person with a vascular problem, vascular claudication, not enough blood supply to the leg, would have trouble being on a bicycle. They would also have trouble with the walking, the same thing that the stenosis person would have. However, they wouldn't have it with just standing. So those are the two differences, standing and bicycle riding. Bicycle riding with a blood supply issue, and standing would be present with spinal stenosis, but not with a blood supply issue. So we have an issue with back pain, leg pain, sciatica. We have all of these tests that we could consider. X-rays are simply a shadow. You get a sense of the alignment of the spine. You can see if there's any instability. You can see if there's anything going on in the bone, like fractures or infections or tumors, other things like that. The CAT scan is an X-ray times 1,000. It's a multiple X-rays in 3 dimensionals. So it's a lot of radiation, and you'll hear in the literature and in the newspapers that there's more of a concern about getting CAT scans these days. Not 1 CAT scan or 2 CAT scans, but there have been a lot of CAT scans done in a population of people who have kidney stones. And it was common that somebody would come to the emergency room, have symptoms that sound like kidney stones. Well, let's get a CAT scan. But there's a lot of radiation for the CAT scan, so there's been a big emphasis on trying to limit that. So, you know, if you're going for a CAT scan, you know, keep that in mind. You know, ask about is this something that is the best test? Is it a necessity? Things like that, because quite a bit of radiation from it. MRI scan, we're all familiar with that. We've heard that. It's a magnetic resonance imaging. There's no radiation from that. That's all done with magnets, and it's done with energy from magnets, which is not a harmful radiation, so there's no harm in that. And the MRI scan sees soft tissue much better than a CAT scan. So if you're looking at things like the disc, the quality of the disc, is there a disc herniation, is there spinal stenosis in the canal for where the nerves are traveling is narrowed, I think you'd always pick an MRI scan if possible. CAT scans are better for bone. So if you needed to look at bone preferentially, the CAT scan would see bony things, like you could see the facet arthritis better on a CAT scan than you could on an MRI scan. So any reason for looking at bone, you'd want to get a CAT scan. But practically, almost all the time, the MRI scan would be the better test. In order to see the nerves better and the canal better, oftentimes we'll make that a CT myelogram, which is actually this picture here. So that is putting a dye in the spinal canal. It follows the spinal canal all the way down, and then the CAT scan gets those same slices, and you can see where the dye goes, where it doesn't go, where the dye is being pinched by stenosis and things like that. So if somebody had a pacemaker and you really wanted to look at the spinal canal, it would be a CT myelogram. You could get EMG testing. That's looking at the nerves. It's a series of needles that go in the skin, and it's connected to wires, and it can tell us, you know, is this nerve irritated at the spine? Is there a sign of a sciatica of the L5 nerve root? Or is it a peripheral neuropathy that sometimes people can get from diabetes or other things? So EMG testing can be helpful. A bone scan is something that is a very sensitive test. It's putting a radioactive tracer in a vein. It goes to all the bones through the bloodstream just briefly, and it makes a little blush of the whole skeleton. And so when you see the picture, a normal picture, you'll just see the blush of a skeleton, and then it comes out of the bones, it goes into the kidneys, and you urinate it out, and that's the test. If there's anything in bone that's active, if there's a lot of increased blood supply for any reason, if it's infection, if it's tumor, if it's fracture, if it's bad arthritis, it'll show up as a bright spot where that dye congregates, and there's a spot. So it's very, very sensitive. So when a bone scan is done and it's normal, I always feel like, oh, there's a sigh of relief. Blood tests, if we're thinking about other diagnoses, blood tests can be helpful. Injection trials, sometimes people have a back pain, and you may think, you know, is the back pain coming from this facet joint? Is it coming from the neural canal? You know, where is it coming from? You may try a cortisone shot here or there, and that may give you information. Here's a picture of the disc, and you can see the discs here on the model. This is about how thick it is. It's really rubbery. The outside part of it is called the annulus fibrosus, and it's the strongest part of it. It's almost like hoops and bands around there, trying to keep the inner part in, which is a little softer. And when it does break down and you get some of the softer inner part coming out, that's what the disc herniation is. And this material it's fairly rubbery, and when you take it and you touch it in your fingers, it's kind of rubbery. In the middle of the disc, it's firm enough to be a great shock absorber, but that's what it feels like. And this is a MRI scan showing a herniated disc. So here's the herniated disc, and it's pushing right on this nerve. This is the main spinal cord centrally, and then two small nerve roots that are getting ready to leave at that level. So if somebody had a leg pain in a particular distribution and had this disc herniation, you'd know it's pinching this particular nerve. So, key age groups, probably 30 to 50. This disc herniation is going to push in the nerve that goes down to a particular distribution in the leg. And the only time when this is an emergency is when this disc fragment is so big that it's taking up most of the room of that canal. And it not only is affecting one nerve root in one part of the leg, but it's affecting both legs. And when it affects both legs, even nerves that are going further down, which is to the bowel and bladder. So people could have incontinence of their bowel or bladder. They may have numbness in their perineum. Anything like that that comes on suddenly is a surgical emergency, and it needs surgery within 24 hours or so. Why is it a surgical emergency? And it's a surgical emergency because it's pushing on all of these nerves so significantly that if you delay in taking the pressure off the nerves may not make a full recovery. So people may have a permanent bowel and bladder incontinence and weakness in their legs and things like that, but not life-threatening.